Great. Well, thanks also for the invitation. I really appreciate it. I am a family physician. I do obstetrics as part of my practice, and my research is around health service delivery. And a few years ago now, I actually looked up Dr. Kovarik and asked her about what her suggestions were for going into this area. And it's really because of what we were seeing on the ground, the needs. Number one, the needs of extending our ability to take care of patients who are getting prenatal care. I focus on low-income populations, and almost all my patients are Medicaid funded, and both within our practice at Penn and also in the FQHCs, where we provide federal qualified health centers, where we provide prenatal care. In Philadelphia, and also in Peru now, where I actually learned a lot of the stuff that we'll be talking about now. As Dr. Kovarik mentioned, the developing world has been way ahead of us with regard to all this stuff, and so many of the principles and the concepts really come from some time that I spent down there. Just wanted to thank our funders and collaborators and mentors, etc., partners, HRQ and the new Penn Medicine Center for Healthcare Innovation that we have some funding for some of the work I'll be showing. The Spirit Participatory Design team made up of patients and providers involved with prenatal care and perinatal depression care. Dr. Holmes, Dr. Ash, and Roy Rosen, who's the new, I call him the czar of innovation at Penn. He hasn't disabused me of that, but I don't think that's actually his official term. But anyway, so let's talk a little bit about perinatal depression. It's a very common disorder. It's very disabling. It's around 9 to 15% of women of all socioeconomic status, and as far as we can tell around the world, have a disorder that can be diagnosed as major depressive disorder. Most women who are suffering from emotional distress actually don't have that. And that is very highly associated with socioeconomic status, where you can have 50% of women being in low-income sites having very elevated depression symptomatology or risk of depression, but turns out that they have something that would not benefit from medication treatment, for example. It is the major source of disability with the highest number of disabled years lived, which is in contrast to years life lost. That's another WHO measure. Depression is the major source of that. And it is associated with a number of things that are interesting to pediatricians and folks dealing with maternal child health, including preterm birth and low birth weight, and the mental health of children, developmental issues as well as growth, actually. And actually, I forgot to mention before I left that slide that treatment is highly effective at reducing the risk of those outcomes. So there are a number of obstacles to perinatal depression care that come from the patient, provider, and the care system that all have focused our interest in extending into mHealth. And I actually am not, in contrast to what Dr. Kovarik was talking about, we're primarily thinking about extending the services that are provided within brick and mortar sites rather than replacing those. And so that's the framework that we'll be talking about here. From the patient's point of view, the low-income folks working in high-volume, under-resourced settings, which actually need more resources because of the disadvantage that the patients are dealing with, are often feeling that they don't feel cared for. That's a refrain that came from some focus groups that we did that I used to kind of characterize this. And there is inadequate training and support within the prenatal practices, usually for taking care of depression in that setting. And the care system itself is not oriented towards proactive care. There's difficulty with following up with some of these patients. So the Spirit group is a participatory design group that includes patients, providers, patients with history of depression and pregnancy, and providers. This very nice woman who did give us consent to have her image and her son's image published was with us in her third trimester when we got started in 2013, and she now has a nice coming up on two-year-old child. Continues to work with us in our work, but this includes also the need to have researchers, developers, film and video producers, whoever you might need to create the products that we end up working on, in this kind of rapid iterative design cycle that is quite well developed within the technology development world, and is very appropriate for developing what I would say is a patient-centered approach to technology development, in which we're actually get the input right from the beginning, even coming up with what projects we're going to address, really using the patients and providers to identify the needs rather than have me sit in my office, which I had done for years, and many people do, and think up, well, what must be the most important thing? These are some images from our meetings that go on monthly, or now actually over the last 6 months, twice a month, because we have a couple projects running simultaneously, where we have, again, these different kinds of constellations. This is within the prenatal site itself. In the evenings, we work for 2.5 hours providing dinner, and actually also pay folks for participating. The non-salaried researchers who are being paid to be there already, but the folks who are having to take time out to come are paid to participate. And there are a number of different kinds of activities that we carry out. There are a range of different products that we've worked on. This is one mobile app that you can get off of the App Store, it is specifically focused on the use by patients who are being discharged from hospitalizations for risk of suicide. And it is called My Game Plan. That's a name that came from one of the designers who was a mother who had lost a child to suicide, someone in their 20s, and really involved working with the psychiatric social workers who are involved with discharge planning, designing the different elements of it in order to create something that's as useful as possible. We haven't evaluated this tool yet. It was created as part of a app challenge, which unfortunately we weren't successful at winning that app challenge. We've won a lot of app challenges, but this particular one we did not, but it's a product that I think is interesting and emulates the kind of work that can be done. Text messaging interventions, that's something we identified really early, was a hole in our service delivery when it comes to young, low-income folks who, as with the developing world, the more under-resourced you are, the more benefit comes from using mobile technology. You don't have to walk somewhere or take 2 buses or dragging your kids. You can call someone, and you can keep balls rolling in ways that you just can't do otherwise. These are we know that close to more than 90% of the low-income women who are being cared for in the prenatal sites that we're targeting have not just cell phones, but smartphones, which extends a lot the opportunities for connected health. And people are puzzled by that if you haven't heard those statistics before. But these folks do not have computers at home. This is their connection with the internet, and it's getting to be you just really can't function. I would say even particularly in a resource way, if you're under-resourced, without having those connections that people need. And one of the things that we found right away, and actually there are a lot of workarounds in the clinic setting, folks who are trying to connect with patients are having a hard time calling them. People will not pick up the phone, and it turns out the reason is, and we're talking about low-income young people, and mean age of delivery over at these clinics is age 25 or 24 to 25. So most folks are under the age of 30, which is the perfect target for kind of cell phone use. And those folks do not like being called, both because they find it annoying, and also because you have to stop what you're doing in order to attend to what someone is demanding of you at that moment instead of responding when you can. But also it's expensive. Just about all these folks have unlimited text plans, but have very limited voice plans. So it just uses up their minutes to have people calling them, and they don't like that. So we found a lot of providers who are actually using their personal cell phones to text with patients because that's the way they can communicate with them. UPHS is in the health system is really, really nervous about that. So we're in the midst of developing and exploring different vendors that will have HIPAA-compliant texting services that can be used and platforms that can be used within the health setting so to be able to work with patients. And One of the learning objectives was to talk a little bit about this, and I'll just mention that the big issues with regard to HIPAA for texting are around security and confidentiality. HIPAA, despite what you might imagine, is actually the point of it was to extend the use of technologies, not to limit it. And it actually, texting cannot be secure because there's just no way to secure text messages adequately. So if you hear about secure communication systems, those are apps that people are using rather than regular text systems. We're very interested in using texting because of the fact that patients use them already. So you do need to take certain steps, including consenting and asking people to lock their phones when they're not using them, and let them know, that you could be getting information that they might not want just anybody to use. So those sorts of communications and reiterating that and making sure that people are not, and also limiting the information that we communicate by text to minimize the risk. Those are all things that are expected around HIPAA. And so it is absolutely doable. The Tips Connect and Tips Connect Emotional Health projects are funded by the Innovation Center at Penn, and those are the ones that are specifically working on text messaging. I wanted to take a couple minutes to talk about another project, though, because it's what we're most developed in. And this is a schematic that's been used for a long time to kind of focus on how to reorganize care for thinking about chronic care. And so I want to focus particularly on the productive interactions down below between the informed, activated patient and prepared proactive practice team. This is a framework that absolutely, I think, guides our work with mHealth. We are developing through support from the Agency for Healthcare Research and Quality a patient decision aid to help people work through what it is that they, the choices for depression treatment in pregnancy that they most be interested in, so that they're ready to communicate with their providers about the different choices that are available. And this is just a framework from called the Ottawa Decision Framework, which includes the decision needs, where you go across there and measure decision quality with a number of different outcomes, and decision support is meant to interface there and help with basically one of the big things is a collaborative decision-making process that should have benefits with regard to overall service delivery and satisfaction. This is just TIPS is the name of that project, which came from one of our patients actually, who was on our Spirit group. It's technology to improve perinatal services. And this is an example of the kind of stuff that we produced in some of our meetings, in which this concept of the value stream mapping, where trying to work through how would this system actually work in the prenatal site. Kind of laying out in an interactive way with patients actually there. Then the developers and the researchers go out and try to create that thing and bring it back to them and have feedback on whether we did a good job. In terms of what the Spirit team wanted, if we're going to represent different kinds of treatments to help people decide what they might want to do, the group decided that evidence of benefit, evidence of harm, and how easy it is to actually do it were the three elements that they'd want to know about the different treatments that might be used. Excuse me. The 9 treatments that we're using for our patient decision aid are listed here, which include a number of things that are less evidence-based but are easier to do and have no risk or less risk to the patient, theoretical or actual, or the developing fetus. These are a number of the components that we would need to have in our app as we're developing, and we're quite advanced in the developing of that particular app. So it includes audio and video delivered either through iPhone or through, not iPhone, a smartphone or through an iPad, a tablet device in the healthcare setting. An interactive to maximize engagement, and that video part is dealing with the issues of low literacy in some of our populations and different languages, etc. Screening for risk of depression, a values clarification process so people go through thinking about what are the things important to them for treatment. stratified presentation of options, basically based on their risk, emphasizing sort of the way that Amazon knows what you would like, or that would be from the values clarification part, but also what you should have that's based on your risk profile that is part of the evaluation, that will have some recommended treatments for you. Then I'll present it in brief videos. There's patient-selected preferences, which then get sent to providers so they can get ready to talk to the patients about it. And I realize you can't really read much of this, but this is a schematic of the different components. One of the things that came as an exemplar of the participatory design, one thing is when you have a paper version of a patient decision aid, people can skip around to different pages. But if you're, one of the things that we thought would be nice is we would force people to go through the different steps of going through the app before they would then look at video clips, think about which treatments, and then have those go out in reports. And what became really clear when we were looking at the video clips themselves, the patients were going to be run out of patience for it. And they really wanted to be able to skip around just as much as if you got paper. So that was an example of major design change that came from working with our patients and providers. This is kind of interesting. We videoed everything with a live actor. These are navigators who are speaking and talking to people through as they go through the app. But it turned out that the computer science folks here at Penn are really interested in avatars. They suggested we explore it. And it turns out that our group really liked the avatar. So we're actually going to use both. And we're planning on having a number of avatars that people can then select who do they want to have to be their navigator. And we'll see, we may end up dropping some of those as we go along. This is just one example. I know we have running out of time, so I just wanted to show some of the graphic components. This is in patient decision aids using, so this is for watchful waiting, waiting to see if you get better on your own, but under supervision, which is one treatment option. This is the one thing where we tell people, starting with 100 people, depressed women, and these little emoticon sad clouds are the folks who are feeling stressed, emotionally distressed. About 9 to 13 will get better just waiting. Watchful waiting would work. And in the end, if you go through that process, then about the same number of people, this is watchful waiting over here as compared to usual care where you wouldn't do watchful waiting, you go right into treatment. There is a little bit of a gap of number of people who don't get better, but it's quite comparable. So this is the kind of strategy we'd be using to help people work through what are the risks and benefits of the different treatment options. This is a quick network architecture. Right now we're staying within the firewall, the UPHS firewall, using tablets to allow people to interact, get the information done, get some reports to the patients and providers, and that all goes in the back end into the electronic medical record environment, which we're using initially MedView, which is a little bit more expansive electronic medical record environment than Epic itself, which we're tying in notifications and stuff, and we'll get there at some point. We're hoping that all this work will lead Epic to influence their design of future versions. Anyway, that's all I had to say. Thanks very much.